Thank you very much, everyone, again for joining. This is the Vancouver Coastal Health Indigenous Health Round. That's a collaboration between Vancouver Coastal Health Aboriginal Units and Intercultural Online Health Network and the Department of Emergency Medicine. I'd like to first do a land acknowledgement. I'd like to acknowledge that this session today is occurring on the shared, unceded, ancestral, and traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh people. I also know that some of you are joining from different parts of our province or perhaps even outside of this province. So I welcome you. I welcome all of us taking a moment just to appreciate the fact that we are able to work and play in our respective locations. Today, we're very fortunate to have two speakers joining us, Dr. David Tu and also Dr. Michael Dumont. So momentarily, I'll introduce them to you. My name is Kendall Ho. I'm an emergency physician in Vancouver Coastal Health. I'm originally from Hong Kong myself. I'm a settler here in Vancouver. And I am also the lead of the Intercultural Online Health Network. It's my pleasure to be here to welcome all of you here. Around that really is a joint leadership. And in fact, the major leadership from the Vancouver Coastal Health Aboriginal Health Unit. Momentarily, you'll hear from Leslie Blanchard, the leader of this group, and also with Ministry of Health sponsoring the Intercultural Online Health Network that I'm very fortunate to be facilitating in moving forward. So let me immediately now invite Leslie to welcome all of you to this Indigenous Round. Leslie.
Thank you, Kendall. Always a pleasure to join you and your guests, Dr. David Tu and Dr. Dumont, my physician partners in Indigenous Health and Cultural Safety at Aboriginal Health, Vancouver Coastal Health. So to introduce myself, my name is Leslie Blanchard. I am from the Shatton First Nation, part of the Stalo Nation, and also the Nooksack Indian tribe on my father's side, the late Siamato. And then on my mother's side, I'm Italian. I have the honor and privilege of being the Executive Director of Aboriginal Health here at Vancouver Coastal Health and have been in this role now for 5+ years, but met Kendall actually when I was at Fraser Health Authority, where I worked with Laurel Jebamani, who you'll meet soon as well. And I just want to say thank you so much, Kendall, for your partnership in this work. Vancouver Coastal Health, along with all of our physician partners, are committed to cultural safety across our health authority in our acute settings, in our community settings. And at every opportunity, we try to create opportunities to share knowledge and to learn through these virtual platforms. They seem to be quite effective because people can still be at their desk, having their lunch, but listening in. I hope that you are listening in today with an open heart and an open mind to take in this knowledge that is being shared with you from firsthand experience from these amazing physicians who have been serving the Indigenous population and sharing with you through storytelling. We find this is the best opportunity to really learn. So I hope that you will give it all the attention it deserves, put aside your distractions and your gadgets for a little while and really honor the stories that these two will share with you. Thank you so much again for allowing me to come in and just do some welcoming comments and commitment of the partnership. And thank you so much, Dr. Ho, for your partnership. Good luck today. I'm going to stay and listen in.
Wonderful. Thank you so much, Leslie. Again, I want to thank all of you for joining us. I'd just like to quickly remind everyone that we are currently recording this session. And the reason for recording is so that we can capture the discussion and capture the presentations so that we can then share it online with others who may not be able to make it here for today. And so just want to quickly remind you of that. And also just to give you a sense about this session, that we have put it in a 1.5 hour time slot. We recognize that some of you may only be able to join us for the lunch hour. And so you may be departing at 1 o'clock. That's entirely fine. We make sure that in our speaking engagements that our speakers will present till about 12:50. So there's some time for us to interact. And for those of you who can stay till 1:30, our speakers will stay certainly for further dialogue and interaction. So I welcome you at any moment. If you have any questions, comments, please use the chat function at the bottom of your screen so you can type your questions, comments. I also want to take this moment to welcome Laurel. Laurel is a colleague of mine I've worked with for many years. Currently, she is in Leslie's Vancouver Coastal Health Aboriginal Health Unit. She'll be partnering with me in moderating the Q&A session together. And so without delay, I'd like to just introduce our speakers so that we can get right into the content. This is the part 2 of our topic, Understanding Dimensions of Wellness in Indigenous Communities, from Principles to Practice. Last time, Dr. Terry Aldred gave us part 1 and really speaks from her heart, her knowledge, and her expertise. And for those of you who are interested, I will certainly put up the link of her presentation on the chat room, and we'll certainly put that up again later on. So you can revisit part 1 if you like. Today with part 2, we have 2 physicians joining us. First, I'd like to introduce Dr. David Tu. Dr. Tu is a family physician, a board member, and primary co-lead at the Kilala Lelum Health Centre at downtown East Side. He's a UBC clinical assistant professor and community-based researcher with a focus on Indigenous peoples' health, HIVs, and substance use disorder. Also, very glad to have Dr. Michael Dumont. He is an Anishinaabe family physician and serves as the medical director of Luma Medical Center, which he helped establish in 2016. He's also a family physician at Musqueam Primary Care Clinic, a clinical instructor and preceptor at UBC's Indigenous Family Medicine Residency Program, and a spokesperson for the First Nations and Aboriginal Primary Care Network. I know that for those of you who were here last time with Terry, she gave us both wonderful principles and ways to put those principles into practice in our clinical setting. I know that David and Mike will do exactly the same today. So with that, I'd like to welcome David and Mike. David, let me pass it over to you and then go from there.
Thank you very much, Kendall. Actually, I'll pass it over. I'll let Mike start get the ball rolling.
Perfect. Thanks, David. Ani Bojo, Michael Dumont, Nidijnikaj, Wabeshishe, Nindodem, Shanagan, Nindunjiba, and Musqueam, Squamish, Tsleil-Waututh, Ninda. What I just said there in Anishinaabe, Mowin. This is hello, everyone. My name is Michael Dumont. I'm Anishinaabe Martin Clan, and my family's from the Shawniga First Nation. I also hold mixed European ancestry. And I'd like to acknowledge that we're speaking today from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples, and also to welcome all of those gathering from other traditional territories across Turtle Island. I think there's quite a few of us from other places here too. So I'd like to thank Dr. Kendall Ho and the ICON project team. Thank you for that generous introduction. To Leslie Bonshore and Laurel Jebamani from VCH Aboriginal Health, and to Dr. Aldred, who gave a really wonderful first talk in this series a few weeks back. I'm really honored to co-present today with Dr. Tu. We wanted to give you the perspectives of an Indigenous physician and a non-Indigenous but trusted ally physician working with our people. And I'm hopeful that this dialogue will be useful and helpful in your learning. So Dr. Tu, I will pass it back over to you.
Thank you, Mike. Thanks. Just by way of introduction, I am a settler to these territories. I grew up in Ontario to immigrant parents, but have been working and living in the Squamish, Musqueam, and Tsleil-Waututh territories for the past 21 years now. Let's get that one through. And thank you all for joining. I know this is lunch and this is precious time, so we'll try to make it as useful to you as we can. So Mike and myself and the other team are hoping by the end of this that you'll walk away with an understanding of some of the historic and ongoing determinants of health and wellness for Indigenous people in Canada. And we're going to take a special focus on systemic racism and cultural identity as 2 important drivers for health and wellness. We hope that you'll be able to describe some of the challenges providing cultural safe care, but also with some strategies that will hopefully improve outcomes for Indigenous people and bring about a greater degree of equity. We hope that you will recognize the role of yourselves as health professionals in this work, as well as the role of traditional elders and the role of culture in improving the health of Indigenous peoples. And I think we'll get to this in the discussion, I think, at the end, of how to be a good ally in this process. Ultimately, the goal, I think, is to try and create paradigm shift amongst all the way we approach this work, and eventually a shift in the system to kind of have a more healthy understanding of Indigenous people, their health, and our roles as partners with Indigenous medicine providers. So I will now just take this quick lightning opportunity to overwhelm you with some numbers. There are about 1.7 million Indigenous people by last official census in Canada, representing about 5% of the population. This population has seen steady increase since 2006 and will continue to be an increasing proportion of the Canadian population. In British Columbia, we have about 6% of our total province identifies as Indigenous. And this is, again, census data is likely underrepresenting. And this community, this population of Indigenous peoples has been urbanized to a large degree. So about 3/4 are living off reserve. And there's this huge diversity in British Columbia. We are so blessed to have over 200 nations or bands, culminating with 27 different cultural groups, 7 language families, and 30 distinct languages. So we really are in such a rich and diverse part of this country with respect to Indigenous peoples. Normally, if we had more time, I would make this interactive, and I'm going to go through this quickly just to kind of make a point that these inequities in health are real and do exist. By last ranking, Canada has slipped to the 16th in terms of the World Health Organization Human Development Index, which is a mix of health and social factors. When applied to Indigenous people in Canada, Indigenous people rank 68th. So that's one example of the gap that there exists to be closed. In British Columbia, the First Nations Health Authority has taken over the reporting of the status of health of Indigenous people. And at last report, there was an increasing gap in terms of life expectancy, an increasing gap in all-cause mortality, and that's represented as an age standardized mortality rate. So that includes mortality from many different causes, as well as an increasing gap in infant mortality. So this is all recent data from the province of British Columbia. Just going through specific conditions, the story repeats itself. There's a 6-fold increase. Hang on, I'm just going to get my kids to be quiet. Sorry about that. A 6-fold increase in depression prevalence, a 2-fold increased rate of suicidal ideation and suicide attempts, and a 5-fold increased likelihood of hospitalization for mental health crises and suicide attempts. With regard to tuberculosis, we continue to see a large disparity, with 31 times the rate of development of active tuberculosis, and more shockingly, a mortality rate from tuberculosis at 2.5 times that of non-Indigenous Canadian-born residents. HIV infection, the story continues to unfold, and we continue to see a higher incidence than expected, and we've maintained a much higher prevalence of HIV amongst Indigenous Canadians. 1 in 70 Indigenous people in British Columbia currently are HIV infected. And the most recent data continues to show excess mortality amongst Indigenous people living with HIV in British Columbia. Similar story for hepatitis B and C, 7 and 4 times the incidence, 5 and 8 times the prevalence. And we see a far skewing in when we look at treatment cohorts that Indigenous people are significantly underrepresented despite their higher than expected prevalence. Diabetes and coronary artery disease, you see a 3 to 5 time prevalence depending on where you are in the country, as well as a much higher incidence of diabetes. Coronary artery disease, similar 2-fold increase in incidence and up to a 10-fold increase in mortality. just relating to the other public health crisis going on that's been ongoing since 2016. We see that Indigenous people are disproportionately impacted by the epidemic of unintentional fentanyl-related overdoses. We see 5, and this is from 2019 data. We saw 13% overrepresentation for presentations of overdose, and that and that 10% of all deaths are amongst some Indigenous people. Again, sort of a 4-fold increase, higher than expected. And in the last year's data in 2020, those trends are continuing in a negative direction, possibly exacerbated by the impacts of the COVID pandemic. So what we have is a story, and this story was, I think, summed in a recent review article published in the Canadian Medical Association Journal this past March. And I'll just quote that: Indigenous peoples in Canada face alarming health inequities, subpar access to healthcare, and culturally discontinuous service. A legacy of the social structural realities of colonialism and racism that includes systemic oppression of traditional Indigenous health knowledge and health practices. And that story manifests itself as one for us in the sort of from an epidemiology perspective of higher incidence, higher prevalence, inferior treatment outcomes, and lower engagement in care. So this problem is real, and it is not new. It is something that we've, as a country, have been looking at for a long time, and that's looking at it both from an Indigenous perspective as well as from non-Indigenous provider perspective. If we look to our Canada Health Act, we see that it assures that Canadians should have reasonable access to insured health services. There was a movement to recognize that there was a problem that needed to be addressed from a rights perspective. And the United Nations made a very strong declaration in 2007, and in 2011, Canada signed on to the rights of Indigenous peoples, the Declaration of Rights of Indigenous Peoples, saying that Indigenous peoples have an equal right to the enjoyment of the highest attainable standard of physical and mental health. In our national reckoning with the residential school system, one of the calls to action in health that came from that was a clear directive to establish measurable goals to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities. And just, I guess, a year and a half ago, the BC government passed the Declaration on the Rights of Indigenous Peoples Act, trying to give some legislative strength to these calls to action. And I think we're still in a situation where we're failing to deliver as a system to provide equitable care to Indigenous peoples. Which begs the question, what can we do? And again, Canada's great at, we've been reasonable at analyzing the problem, and this is from a 2009 Senate Standing Committee analysis, sort of a 500-page tome. You can summarize the preamble by saying that these health disparities are a complex interplay of historical and current social, political, and economic factors, resulting in marginalization and exclusion of Indigenous people. This tome attributed 60% of these disparities to the fact that Indigenous people have experienced a loss of land and a suppression, or really, I think we can call it an attempted genocide on their individual and community identity. But it does squarely say, this report, and I think this finding still stands, that 25% of the disparities we see are attributable to the health system. This is quantified as poor attachment, as well as a clear lack of resources and structures. So if we're trying to steer our way forward, one thing is to look at, okay, well, we need to make an investment in resources and structures if we want to achieve equity. And as well, we have to address attachment, which is a very system-centered, and I'll bridge to Mike here, just the colonial nature of that term, of becoming part of a larger system. And I think I'm going to put it to Mike to talk about what some of the reasons are that that attachment is such an issue. But I think in the end game, all the strategies need to be working towards these two things: increasing resources and increasing the ability for people to receive quality care. Over to you, Mike.
Thanks, David. Yeah. So I think these are, as you said, sort of terms that we use within the system for how we provide care for Indigenous people. And I'm hoping we can reframe some of this as part of our discussion to looking at well, what does this system look like to access for Indigenous people? What does it look like from our perspective as patients within the system, coming to access care? Do we feel safe? Do we feel a sense of trust in this system, or do we feel, fear of the racism that unfortunately we know so many examples of? So we'll talk a little bit about that with some of the cases that we have and the stories that we have to share today. I wanted to start with a couple of definitions here. So this is from the In Plain Sight report, which I'm sure most of you have heard of, but it's basically a large basically inquiry that was done last year, published in November, looking into Indigenous specific racism within the BC healthcare system. And we'll talk a little bit about some of the findings of that report. It really shares a lot of the story of how the healthcare system has been a place where we've been harmed as Indigenous people, certainly here in BC. So colonialism as a term that that we refer to in terms of how groups of people come to a place or a country, take resources, take the land, and set up laws and public processes designed to violate human rights of the Indigenous people, suppress their right to self-governance, to legal, social, and cultural structures, and force them to conform to the norms of that colonial state, and usually in a subservient role. Racism, which we'll talk about quite a bit here, especially as a determinant of health, that is the belief that a group of people are inferior based on the color of their skin or due to inferiority of their culture or spirituality. And that leads to discriminatory behaviors and policies that oppress, ignore, or treat racialized groups as less than non-racialized groups. And this is certainly not a story that's unique to us just as Indigenous people in this country. Certainly our allies in the Black community, and now more recently, it's certainly in the media anyway, how Asian Canadians are being treated in this country. There's, I think, if it gives me any hope, at least, is that these discussions are coming out into the popular media, and then we're seeing recognition that there is a huge problem in this country too. This isn't just an American problem. This isn't just something that's happening elsewhere. This is happening here. We've got a problem ourselves here with this as a country. And Indigenous specific racism refers to the unique nature of stereotyping, bias, prejudice about Indigenous peoples in Canada that's rooted in this history of colonization. That there's ongoing race-based discrimination, negative stereotyping, and injustice experienced by Indigenous peoples that perpetuates imbalances in power, systemic discrimination, and inequitable outcomes stemming from these colonial policies and practices. The Indian Act, the laws that govern how we relate to the state. The racism is rooted right in the very fabric of Canada's Constitution. So anti-racism, the act of rejecting racism, I really want to stress the importance of this being an action. This is an active state. It's the practice of identifying, challenging, preventing, eliminating, and changing the values, the structures, the policies, the programs, practices, and behaviors that perpetuate racism. It's more than just a passive claim to being not racist. I think of one of the sort of prominent scholars in this area right now, Ibram X. Kendi. One of his sort of quotes that burns into my memory is that you making a passive claim saying, "Oh, I'm not racist. I don't see color," is in itself an act of racism. That's denying the lived reality of the racialized population, and that in order to be anti-racist, you need to make a stand. You actually have to say this is wrong, and actually take that step to reject those statements that you hear or those policies that you see that perpetuate the imbalance in power. Cultural humility is a lifelong process of self-reflection and self-critique. So this is tied very closely to the concept of cultural safety. And a culturally safe environment can only be defined by the person receiving care. And it does not profile or discriminate against the person, but experienced as respectful, safe care, and allows meaningful communication and service within the space that the person's receiving care. It's a socially, emotionally, and spiritually and physically safe environment without challenge, ignorance, or denial of an individual's identity. To be culturally safe requires positive anti-racism stances, tools, and approaches, and the continuous practice of cultural humility. So all of this sort of works together. You know, you'll certainly hear more, more of a push towards anti-racism in our workplaces and in curricula for medical schools and other professional health professional schools. But it's really all part of the same journey. We're really trying to get to a place of cultural safety for all peoples, but especially for Indigenous peoples in the healthcare system, where there is that historical disconnect. So I'll bridge into our first case here. This is a patient of mine whom I see at Lelum Medical Center. I've changed the name and some of the identifying information here. But her story, I think, highlights some of what we're seeing and highlight some of the challenges that the In Plain Sight report brought up. She's a 47-year-old female, mother and grandmother. She is status First Nations and comes from a community, lives here in Vancouver now, but her home community is a Coast Salish community not too far away from Metro Vancouver. She has a history of severe lumbar spinal stenosis. So for the non-medical people in the crowd, basically she has a narrowing of the spinal canal in the lower back region. So it crowds out her nerves and the bottom part of her spinal cord. Leads to debilitating chronic pain, and she gets pain that shoots down her left leg and basically makes it very difficult for her to walk much more than a block at a time. Basically is completely taking over her life. She has obesity with an elevated BMI. Unfortunately, she's also had multiple blood clots, so fairly severe blood clots that were life-threatening. So she's on a blood thinner called warfarin. She's seen 2 neurosurgeons about her back, who both said that she's not a surgical candidate because of the high risk. Basically, because of the blood clots, they can't operate safely without putting her at risk of dying on the operating table. She's also seen a few chronic pain specialists. Her main specialist has basically come to the conclusion with her that long-term opiate medicines are reasonable and warranted given the level of pain that she has and the fact that we really don't have any other options to treat her condition right now. So she's been taking regular hydromorphone, so an opiate pain medication, a fairly high potency pain medication, since 2012. It's the only medication that gives her some measure of relief. She's tried just about every other treatment. We've tried probably about 12 or 13 other pharmaceutical medications. She's tried procedural pain treatments for her back, so needle-based therapies, physiotherapy, massage, chiropractic, you name it. She's literally done everything that there is to get some relief, and this is literally the one thing that helps her. She has no prior history of substance use disorder, and she's always been on time for her medication refills and always seen a single doctor for her opiate medications. And that's a standard practice just to help prevent diversion or inappropriate use of those medications. You can go to the next slide, David. So this is a few years ago. Her original family physician retired in 2016, and she was transferred to a new family doctor, family physician in that same practice. This is in East Vancouver. Now, this is around the time where our provincial college, the College of Physicians and Surgeons, had basically said that they had issued some new guidelines for physicians about prescribing opiate pain medications for chronic non-cancer pain, and basically encouraged us to de-prescribe where possible. And a lot of patients who were established on these, these opiate pain medications found that their doctors were trying to get them to taper down. She was told by her new physician, I'm going to have to cut you off, and told her that she was at high risk for addiction. My patient sort of was quite affronted by this and said, what do you mean I'm at high risk for addictions? And then the doctor said, well, you're First Nations, aren't you? And so this was a very difficult moment for my patient to navigate in that room with that doctor. And she, she's very humble, very shy, individual. I don't think she felt a sense of personal agency to be able to challenge that notion and what that doctor was saying. But I'll pose this question to the audience here. Was this an example of racism?
Please use the chat if you can.
Yeah, I think we have everybody muted, so it'll be through the chat. I'm seeing a lot of yeses, an avalanche of yeses here. Okay, I don't think we have too much discussion on that, but does it matter? Does it even matter if this was racism? Do we need to objectively define that to call it out or to call the individual in to try and change this? And I say that as an open question, sort of a rhetorical question, but I think personally anyway, it really comes down to what the patient feels and what TA felt in this moment. And she very much felt that this was she was being racially profiled, and this felt like racism to her. She was in a place where she had absolutely no other options in terms of treating her pain, and she felt that she was being unfairly treated. When we talk about cultural safety, one of the key things that we talk about is it's from the perspective of the person receiving care. That's who defines whether this interaction was safe, and she did not feel safe in that moment. You can go to the next slide, David. There. So she basically they made a plan to taper down off of the high dose of the hydromorphone that she was on. And shortly into that tapering process, she returned to the doctor complaining of some pain in her left groin and hip area, which was not unusual for her given the way her chronic pain in her back went. She sometimes would have pain in that area too. But anyway, the doctor didn't examine her and advised her that this was just the withdrawal phase of her tapering down on the medication and that it would improve. She ended up going to the Emerge about 3 days later with severe pain, not having had a bowel movement in a few days. And they found that she had a hernia in her groin, basically a part of her bowel that had been stuck and choked off, and actually the blood flow had been interrupted to it, so it was incarcerated. So quite a severe issue, a medical emergency, that she actually had to have emergency surgery. So this case, and shortly after coming out of hospital, she ended up coming to our clinic. But this is a case that I think highlights a lot of what Indigenous patients face in addressing or in coming to the healthcare system in this province. In plain sight, made a number of in the process of the inquiry, came up with a number of themes that Indigenous patients reported in terms of the care that they received, stereotypes that they endured, and some of the harms that came from that. So as a result of discrimination, Indigenous people do experience harm, poor quality of care, and even death. Women and girls are disproportionately negatively impacted. Women interact more frequently with the healthcare system, and there's more opportunities for this to happen. Are subjected to misogynistic stereotyping, specifically as Indigenous women. We'll get to that in a moment here too. And that there's actually a greater gap in health outcomes between Indigenous and non-Indigenous women compared to men. So some of these stereotypes are that we are less worthy of care. You can just click through these pretty quickly here, David. That we're drinkers or alcoholics, that we're drug seeking, And this is certainly one that I think that the patient that I just brought up faced, that we're bad parents. There's lots of judgments that get made and around our ability to parent. And certainly there's the overrepresentation of Indigenous children in government care. This puts a lens on us as Indigenous parents, when we're seeking medical care for our children. That we're frequent flyers, we're frequent users of the, especially emergency services, that we don't comply with instructions that our providers give us, somehow that we're less capable or responsible of looking after our care, that we're somehow always getting stuff for free, or that we're unfairly advantaged by the way the system works. As a result of this discrimination, we do experience real harm. We don't get the same quality of care that non-Indigenous people receive, and the consequence of that can be death. So these are some of the harms that have been reported by patients in the inquiry, that we've had unacceptable interactions with staff. So hearing disparaging or racist comments specifically to us, or overhearing them about us, getting cold treatment, having to face long wait times or denial of service, just the feeling that we're being made to wait longer than other people, that there's a lack of communication or shunning of Indigenous patients, that we get shut out and disengaged from care. We get talked about in the hallway, but not engaged as shared participants in making our decisions for our health. That our concerns aren't believed or are minimized. This is a huge one here, that there's inappropriate or no pain management. There's the idea that somehow that we're drug seeking, or that we won't be able to appropriately take the medication, and so many people go with untreated pain. That we receive rough treatment, so sort of manhandling treatment and higher use of physical restraints, even against guidelines. And that there's a large degree of medical mistakes. So TA's case brought up basically a missed incarcerated hernia. That's a pretty big miss. Thankfully, my patient had enough agency to take herself, get herself to the hospital in time. But I know a lot of patients who don't. They have that real severe fear of going in, even with an urgent medical concern like that. And the outcome could have been different. Lack of recognition or respect regarding cultural protocols. This is a huge one too, especially in hospital settings and in clinic settings where we don't allow cultural protocols, smudging and brushing down and ceremony and the gathering of family. And so this is a really important thing that we need to change. So overall, probably most dangerous of all, many Indigenous people avoid the healthcare system in anticipation of this discrimination. So that lack of trust is it's a massive barrier to us receiving the care that we need. And linking that back to what David had said earlier, we have a difficult, there's a problem in our system in terms of attachment, and this is probably the fundamental part of this, is just a lack of trust. So how do we change this? Confronting racism. We need to acknowledge our own implicit biases, our internalized, we're not blaming any one individual for this, but that piece that we bring into an interaction with our patients, our own implicit biases, what we've been taught by our society and by our systems, that perhaps isn't helping that patient, and the systemic racism that comes with that. We need to acknowledge the identities and lived experiences of our patients, institutionally, trying to confront those policies that do perpetuate the power imbalances, and we need to call out or challenge. And when I think I'm hearing Terry in my ear right now, call in those people that are making those comments rather than call out. These are our colleagues and our people we have to work with. We need to include them in that discussion and trying to make things better, and basically create a culture where it's not okay for these things to be said, and not okay for these judgments to be made. So anti-racism is an action. It's something that needs to be done actively, not you can't make that passive claim to non-racism and not do anything. And the other piece here is just, cultural identity is such an important thing for us in terms of this sense of strength and building that sense of safety in accessing care. And this is a quote from White Standing Buffalo. Wellness reinforces and is reinforced by a sense of cultural identity. I know David's going to go into this in more detail, so I won't dwell here. But the inquiry did identify two key areas: that Indigenous health practices and knowledge, they're not integrated to the healthcare system in a meaningful and consistent way, and that needs to change. So we need to find ways of bringing in healing practices and traditional medicines into these healthcare settings. And that's not only just to improve satisfaction and sense of safety. This actually has demonstrated benefit for health outcomes. Cultural identity is a determinant of health, and that there is a tragic lack of Indigenous representation in leadership roles in healthcare, and that also needs to change. I am going to run us over time here, so I'm going to pass it over to you, David.
Thanks, Mike. So I'm going to try and whip through some things and leave us some time for questions before people have to leave. So I'm just presenting a case that was top of my mind today, actually. I put these slides together just really yesterday. And this is actually, coincidentally, an important day in Mary's life, and I'll explain in a moment. So Mary's not her real name, and I've kind of protected her a little bit, but she's a 30-year-old woman in my practice. She's a single mom, 2 kids, 10 and 5. She lives in a supported housing environment in the downtown east side, and she spent most of her life growing up in the foster care system. And she actually served me notice early February saying, this is going to be a horrible time, and just being overwhelmed by the grief of multiple losses. And today is in fact the 1-year anniversary. This is just a strange coincidence of the death of her son, who was a unexpected term death, a stillbirth. And it's the same month of the anniversaries of the death of her sister and of 2 of her brothers. So she was very clear that this was going to be a problem. And so how to approach someone like Mary and how to help her. So just a couple of strategies. One is actually understanding the context. And I'm going to whip through this, but understanding that colonial history does shift our own paradigms of thought of how we understand Mary's situation, and also being aware of that this isn't over. There's still ongoing national, local issues that are affecting people's health, particularly the child welfare system. I'm gonna the history lesson is something we should all know, but this is the backdrop that the Canadian government, as well as the British government before that, was engaged in a process of colonization, and it was front and center. And really only steps to try and undo that process have really only date back over the last 70 or so years, making an attempt to redress the policies and systems that were put in place. I just want you to imagine, this is a fictionalized family history of Mary, but just imagine that going back 5 generations for Mary, there would have been a time 100 years ago where there was just a decimation of the population. This is rooted in historical fact that, in 1825, Cook identified in his explorations that there was an estimated 300,000 Indigenous people living on the north coast of BC. In 1925, there was estimated 21,000 people remaining, so a 90% reduction. And those deaths were a result of colonial factors, forced relocations, war, illness, exacerbated by the introduction of, at around the turn of the century, of the residential school system, where only about 50% of children that went in came out. The impact from generation to generation, the loss of language, the traumas experienced, the use of substances, alcohol, and others as a mechanism for coping, the loss of connection to culture, ways of parenting, and others, all fold out to the fact that Mary right now has already lost 4 of her siblings, and she lives a very complicated life. This is further complicated by the role of colonization in the health system, and again, the In Plain Sight spells it out in very clear language. why our health institutions have a deficit of trust with respect to Indigenous people. It's a nice quote. To this day, I have people in communities who tell me they do not want to go to hospital for care because that is where their grandparents died under atrocious conditions. So there's a hole that we need to dig ourselves out of. And again, just an aspect of hope, something that certainly moves me in my professional practice, is that cultural identity is a pathway forward. We can recognize what colonialism has done to cultural identity. Cultural identity is not a static thing, but it depends. It's an active process that allows people to practice who they are and have support for that identity. And we see lots of beautiful studies showing that where there is a positive sense of identity, the number of native language users, the participation in cultural events, you see remarkable synergies with improved rates of youth suicide, diabetes control. And I think this all roots, this sort of sacred tree diagram, I think just gives us a way of understanding the determinants of health. That those distal determinants of colonialization, the Potlatch Law, the 60s Scoop, the Indian Act, are the drivers for the current circumstance of poverty, inadequate housing, racism, economic security. And we see those represented as if individual populations were leaves on a tree as the illnesses. And cultural identity is a mitigating factor sitting in the middle there. And one of my own recognition as a physician is there's very little I can do as a non-Indigenous physician, settler on these lands to impact someone's identity in a meaningful way. But there are people who are able to do this. And those are the elders recognized by Indigenous communities. And these are some of the definitions of what makes an elder. Understanding the person, Kendall's giving me my 2-minute warning. So I'm just gonna whip through. Just knowing that I've given you a lot of population health data, we've talked a lot about systems, but there's a person in front of you. Knowing that person's story and being engaged with that person as who they are is what actually makes the difference at ultimately a population level. There is a complex story to Mary's history. And it really does center around the fact that her family wasn't able to care for her, that she was lodged into the foster care system. Her sister she actually stayed with her sister throughout her navigation, but her sister died in 2017. But there's also strengths to work with there. She's reconnected with her community. When she became a mom, she was determined not to repeat history. Utilizing this relational approach to care. And again, there's lots of tips, and you can all get these in the Indigenous Cultural Competency course if you like. But it's just really, the call is to just be a good human being and do all the things that you were trained to do and how to engage people well and effectively. Be present, show respect, listen, acknowledge diversity of opinion, bring your own humanity, embrace humor, advocate when the opportunity presents itself, and be trustworthy. In the case of Mary, since February, I've been connecting with her weekly, or the nurses have been connecting with her weekly. The counselor who works at Kilala Lelum, as well as the social workers, are keeping on top to make sure that she has all of her needs from emotional and social perspective. And she's been actually working with one of our elders at our clinic, as well as the cultural wellness team. She's been attending circles with her children. And actually right now, if I wasn't giving this talk, I've been getting pictures and texts of a burning ceremony that's happening just to honor. That's just a little photo of, there's a ceremony that's been put together to allow her and her children to mourn the loss, the multiple losses that she's had. And so that, there's no way that myself or the best nurse, the best social worker, the best counselor could have put this ceremony together. And I think the ceremony has been what's giving her hope throughout this month. There's been research and study looking at the impacts, and I'm just going to whip through the study that we did. Basically, it brought together Indigenous elders partnered with medical providers, both from the primary care and the mental health perspective. and it developed a platform of shared understanding, shared goals, respect, and communication. We had excellent retention. People engaged with elders very well within the group, and we saw statistically and clinically relevant decreases in depression, suicide, and emergency room visits. And this is all in a publication from 2019 in Canadian Family Physician. Again, that sort of decreased crisis presentation to emergency room was particularly, seemed particularly validated. More importantly were the stories that we held, and we don't have time to share all those stories, but just knowing that elders place an important part in people's lives, and they fill the gap that the current primary care system often doesn't, providing a place where healing can actually occur, strengthening that cultural identity. They are bridged to trust, to the larger health systems. They provide ways of coping with loss, and I think the case today of Mary is emblematic of that. Something that the standard typical health system could never achieve, and able to bring in spirituality, which is actually a remarkable thing to witness as a care provider or someone who aspires to be a healer. So again, there was conclusions that this makes sense. This is what people want, and this is effective, and we should be doing more of it. And we should be looking at it more critically. I know the study took basically the Black representing a primary care clinic trying to do the best they can, made space for Indigenous culture, and it had a good impact. I think the future looks a much more balanced view. I'll speak to we're the new kid on the block, Kilala Lelum.
David, can I get in for a moment? I think just knowing where we're at with time, I wanted to make sure that people have, if anybody wants to ask any questions, maybe we can come back to the clinic introductions after one.
That sounds perfect. So we'll hand it over to you, Terry, to field the questions for the 6 minutes remaining.
Excellent. Thank you very much. Momentarily, I'll ask Laurel to kick us off on the moderation. David and Mike, thank you so much for excellent content. I feel really bad myself for cutting you guys off, so really apologize for that. For those who have to leave at 1, we will have 5 minutes, but this round will go till 1:30. So for those who can stay, we'll have much longer period of time of interaction. So just want to clarify that point. So Laurel, maybe I'll ask you to help us kick off the first question.
Sure. Well, since Jay Hutton has asked about questions outside of the 1 o'clock time, I will go back to a question that they asked at the beginning, and that is, how do we ask about Indigenous identity of our patients in a safe and respectful way?
Mike, I know I could put my stance on how I do it, but Mike, I know you've done a lot of work in this. Do you want to take that one first?
Sure. No, I think probably helps to hear both of our perspectives, Indigenous and non-Indigenous there too. Start by introducing yourself. Introduce yourself in a respectful way, and then you make that sort of. It does a few things. It helps to bring that sense of power imbalance between the provider and the patient down a little bit, and you can also basically in code speak, so to say, you could basically show that you do understand some of the history. You understand that protocol of how to acknowledge territory, acknowledge space, and acknowledge who you are within that space as a settler or as an Indigenous person. And then it welcomes your patient to introduce themselves in the same way. That's how I do it, with my first visits with my new patients, which is easier in a community setting than it would be in in more of a tertiary care space. But I think it's still very quick. Once you get comfortable doing it, it takes 10 seconds. And I think that's a good way of doing it.
Yeah, Mike, I totally agree that starting with your own introduction, putting yourself in the spotlight first, and identifying myself as a settler, acknowledging the territory that I am a guest upon, acknowledging how I identify myself. I'm half Chinese, half Welsh, and I'll put that out there, as well as a bit about what I do and who I am, that I'm a father, that I'm where I hold privileges, and do take time for an introduction. But it is less. It's a minute, But that first visit, it's well worth it. And then it is a loaded question to ask people how they identify themselves. And so you do have to read your room to know when it is, if it's okay. Often a safe first question is, are you from Vancouver? Because many people are from Vancouver, but that's majority are not. And that opens the conversation. So if you're not from, if you're not from Vancouver, where are you from? Or if you are from Vancouver, what part of Vancouver, where are you connected to? Where are your parents from Vancouver? As moving from sort of very safe space to a conversation. And if people who know the value of the importance, if culturally, of where you're from, and I can think the same of Chinese culture, of where you're from is exceedingly important. People understand where you're going with this question. If you, especially if you frame your own sense, if you've localized, given the location of where you see yourself on this territory. And that opens the door for discussion. And and the answers do change sometimes over time. Some people don't share their identity on the first visit. And it does make sense to come back to it. You got opportunities when you're talking about family history, when you're talking about, when you're asking questions around, if you're doing a new intake, if you're doing a good social history around, special diets, spiritual beliefs, there's windows where people can have an opportunity to talk about their identity. But it's a quid pro quo. You got to be willing to give some of yourself as well, and level the playing field. So.
Excellent. Thank you very much. The second, maybe I'll lump two questions into one. David, is related back to the early part of your presentation, especially about the statistics and the background. One question is, W. Margets asked, the right to clean water is one of those main issues. And also, Yvonne, iPhone Yvonne asked, those statistics, could you clarify if Métis and Inuit are being factored in as well as non-status First Nations?
Maybe I'll talk to the data first in terms of the data quality it's heterogeneous data. So some will accurately identify, include Métis people, will include on reserve, off reserve. Other studies are limited to only on reserve because that's where a lot of data sets come from and excludes a lot of people. So the answer on the data quality side, it is you have devil's in the detail. You have to look at each piece to find out which specific population. And again, we have heterogeneity across this country in terms of health and status. So, knowing that it's from Ontario or if it's a Quebec study, that matters. So I tried to put as much BC related data as I could in those slides. Mike, the rights and the rights to water is an important one. Do you want to?
No, I appreciate you bringing that up. I didn't catch your name, whoever wrote that, but it gets back to, I know I've referenced that slide a couple of times now where David had sort of parsed out where some of those gaps in outcomes and health outcomes are between Indigenous and non-Indigenous people in this country. And it gets back to that bigger 60% where there's inequitable access when we've been dispossessed of our land, of our family connections, of our language, of our culture through many of these policies and the effects of colonization. And part of that is that we are, many of us living in small reserve communities. These aren't the fertile valley bottoms of the desired places to live. A lot of the time it's swampland. It's land that's that's been tarnished by tailings from mining operations. That isn't suitable for agriculture or other sort of uses. And it's very difficult to get safe water in these spaces too. And it's a real tragedy in this country that we're one of the wealthiest places in the world, and yet there are numerous First Nations communities in this country that are still on a boiled water advisory or have been for dozens of years. It's something that we've heard a lot of promises from governments about changing and seen frustratingly little progress in terms of anything being done about it. We have had some local successes. I think about the Samiamu First Nation making that that agreement with the, I believe, was it the city of White Rock or city, I guess city of Surrey technically, but to get access to clean water for families there. So there are some examples of successes that are happening, but it's been painfully slow and really honestly a national embarrassment that this hasn't been moved further at this stage.
Thank you so much, Laurel.
I saw a question that is definitely one that's close to my heart, and it's around addressing structural racism and how do we, what steps can we take to change inherently racist structures such as a healthcare system without dismantling them? What do you recommend as initial steps?
I think that's a great question, and loaded within there is a question to dismantle or to not dismantle.
That's what I was thinking too.
And I remember posing that question, that same question, actually. I was with a circle of very thoughtful and experienced elders, and there was about half, the room was split. Half said, we need to dismantle. It needs to be taken down. And the other half said, okay, no, we can have enough faith to change from within. My own experience in sort of primary care is that it's very difficult. Our systems are quite rigid. They're so complicated and interconnected, and there's so many factors that limit the way we are able to engage, and who has space and who has financial space, intellectual space, in order to provide care. That there is a degree of dismantling and rebuilding that I think does need to happen. And but the thing with, it's like we're looking for a major renovation here. I think is a reasonable analogy, as opposed to we don't need to take it down to the ground and blow up the foundation necessarily in all cases, but prepare yourself for some pretty heavy lifting and some pretty being uncomfortable, having to kind of live with your kitchen kind of torn apart and your bathrooms torn apart as you rebuild. And I think both Mike and I can speak to some of the pains of having to try to rebuild or construct a system that makes a bit more sense for the community that we're looking after. And if there's time, we'll share a little bit about the story of Luma and Kilala Lelum afterwards. Mike, you want to take that one? I'd love to give it to Leslie as well. I think she could throw in that too.
Well, I think about, I mean, there's always opportunity to build new ways of doing things. I think our two clinics are examples of that locally, but we're building the new St. Paul's Hospital. You know, I live very close to there. It'll be 7 years, I think, before we're done that. But there's a great opportunity to change structurally how that space looks, and I think we'll have opportunities for renewal within the healthcare system with the different places, different programs. I think we just need to really incorporate Indigenous cultural safety as a fundamental factor that we always have to consider with any new program, with any new initiative. To bring elders and knowledge keepers and stakeholders from Indigenous community in on all of those decisions that are being made right at the top level. I think the opportunity lies in really just changing that relationship in terms of how Indigenous people are consulted on those decisions. So I'm excited to see how Providence and St. Paul's works in that new space, in that new area, building the new hospital. But I think in the community with these, with centers like the ones as part of our network, the Indigenous owned and operated clinics, I think we're perhaps showing a way that this can be done differently, and you're seeing changes even within the system too. Like VCH owned and operated clinics have had partnering elders in the clinics for several years now, and the new urgent primary care centers, are incorporating elders as part of their care teams as well. So there is, I think, ways of getting that incremental movement towards good change. I don't think we necessarily have to burn it all down. But there's a part of me that feels like sometimes you need to make dramatic change in order for for things to really, for the system to really see the importance of why that change needs to happen. So
I might just add before
answer, non-answer.
Before Leslie weighs in, I think the In Plain Sight report and Mike's slide previous kind of alluded to the two-pronged solution is actually making space for Indigenous medicine providers, but also putting Indigenous people in positions of leadership in the decision-making process. And I think those two are to get meaningful change, you need both of those things to happen. And I see that represented at LUMA. I see it represented certainly in the sort of board structure and the governance of Kilala Lelum. Leslie's chomping the bit, so I'm just going to hand it over to Leslie.
No, I'm just agreeing, and I'm going, yes, you two are already covering it all, but absolutely, status quo is not okay. So that's the main line, right? That's the tagline to everything. In plain sight is truth telling. It is the final truth telling we've been waiting for. All along, we talked about the history and the experience of Indigenous people from hearsay, from anecdotal. I heard from my mom, I heard from my aunt, people telling stories. And now Mary-Ellen Turple-Lafon and her fabulous team have been able to tell the full truth by doing it in an inquiry format and then reporting it. So there's no more denying it by the health system that there's racism in healthcare, right? So we know that now we must disrupt to change. And so status quo is not okay. Whatever we've been doing yesterday is not okay. We're always looking forward to some sort of change so that we can change that narrative. And so that 10 years from now, when she does another report, and she will be asked to do another report, we must see significant change. And how we do that is through making more opportunities available for Indigenous people to lead, Indigenous people to participate, such as Michael, myself, our elders, and we're disrupting that power imbalance between the colonial bureaucratic system, the Western medicine system, to evening out with the Indigenous way of knowing and the Indigenous worldview, which is what David's beautiful publication absolutely spells out for us. Thank you for letting me weigh in a moment.
Excellent. This is fantastic. So we'll go into the question, but I learned one thing from my kids. When you watch a movie, you should watch past the credits because there are some post-credit scenes. So I will be coming back to David and Mike so that they can talk about the clinic a little bit later on. So watch out for that post-credit scenes where they give you some additional thoughts. Thanks for Janet for highlighting Secret Life of Canada as a recording. As a podcast, you can look at the chat to look at that. The next question, Mike, is for that case, number one, how you've given us some general principles of how to call out racism, how to address it in a positive way. The question was, for this particular doctor, what can we do and where do we go for that doctor in that particular case? What are your thoughts there, Mike?
Was the question, I guess, where do we go with the doctor who had basically provided the what we're calling out as racism here?
Yeah,
Racist
so
care?
you have one-on-one. The doctor display this approach, and so how do we support? How do we engage this doctor, and how do we do that on this kind of one-on-one situation?
Mm-hmm. It's tricky in this situation because this was in a private clinic, and this had happened in the past. I met my patient after all of this had occurred. We spoke about, whether she wanted to make a college complaint, whether she wanted to bring this forward, this is one place that you can be a good ally here is in supporting your patient who's gone through a difficult experience to make that complaint. That complaint doesn't have to come directly from the patient. I'd argue from an ethical point of view that that you should certainly include them in that process and respect their autonomy. And if they really don't feel comfortable bringing that forward, then not to. But that's what happened in this situation. My patient did not feel comfortable bringing that forward and making the complaint. And so I respected that wish, and we didn't actually do a confrontation. But if you're in a situation where this is somebody working in your clinic, in your office, in your hospital, and you witness it, I encourage people not to make it a shaming process, not to feel like you need to publicly out the person for making that statement. But I can't in my heart believe that any of us want to be racist. I think there are very few people out there who take any pride in saying things or doing things that are truly discriminatory to other people. And I think you find a way to quietly bring that person aside and in a private setting and as a first step anyway, and say, what I just wanted to let you know, what I saw there made me uncomfortable, and here's why. Make it about what you observed, not about what they did, but what made you feel uncomfortable, and just see how they respond. I think 90%, 95% of colleagues working in the healthcare system are going to be shocked and horrified if they realize that what they said came across as racist or discriminatory. And I think that can make a really big change. I've had a few of those conversations with people in my short career. I can say with one exception, they've come across, they've actually been very positive interactions, and if anything, it's probably made me feel closer to that colleague from having that confrontation, so to speak. So it doesn't have to be a grand gesture or a shouting match in the hallway or anything like that. It can be just a quiet heads up. This didn't look right. This didn't sound right. I don't think you meant this, but this is what it looked like to me.
Excellent. I know David want to jump in. Can you unmute, David? I know we're working on that piece too. Oh, not yet. Maybe Brenda or Anne-Marie, could you help unmute David so he can make a comment on there? Oh, not quite. David, we'll come back to you. So if you can hang in there, we will get you unmuted. Laurel, perhaps the next question.
Sure. Thanks, Kendall. I saw a question from A. Godding about an elder who comes to their clinic weekly, and how could they increase the influence of that elder in the clinic?
Great question. I think my first inclination there would be to ask the elder, what does the elder feel about their role within that space. And again, I'd encourage other clinics to look at the leadership structure and their board governance and that sort of thing. I think elders can be obviously like crucial team members in terms of service delivery, working with patients directly, but in terms of guiding an organization, I think elders and knowledge keepers from Indigenous community can maybe David can speak to this, perhaps even better than I can with how Kilala Lelum is set up. Having elders as part of that board of governors, board of directors rather. Within an organization can really help. But practically speaking, I think trying to help that elder be more visible within the space. One thing that we've done at LUMA, whenever one of our elders doesn't have a sort of a scheduled time where they're with somebody, and when we're not in the middle of COVID, we ask the elder to actually be out in the waiting room and to actually have that sort of just. It's amazing how it changes that space, and just having an elder in that space to welcome people and just open up conversations. Like it changes everything from how that patient's blood pressure is when I see them, 10 minutes later to just how ready they are for change, for whatever else they're going through in their life. But you know, try to make the elder more visible and more you know, so people really know, patients really know what their role is and what they do as part of your team.
David, welcome your comments. Oh, David? Oh no, David froze. David, are you still there? Ah, all right, so close.
Lost David.
When he comes back again, I'll call on him. That's
I
great.
could add a little bit more.
Oh yeah,
Kendall.
please, Leslie, go ahead. Go for it.
So we have been able to, you know, recruit, for the lack of a better word, many elders as care team members in our Vancouver Coastal Health run primary care clinics as well. And what has been most interesting is, although they've come on as part of the care team for the patients and clients, we have found that the staff have been the most rewarded by the participation of the elder, and have often said to us, you know, they'll pick up the phone and say, is there any chance I can have a session with the elder too? So really, you know, that's an unintended consequence and a wonderful outcome, that the elders are actually able to support staff too. And all of us know that during this COVID year, all of us have been draining, and, you know, in any way that the elder can support, I think that's an amazing opportunity for staff as well as clients and patients.
Well, thank you very much. I think when David comes back, I'll get him on. In the meantime, I'll go to the next question. And in fact, it kind of follows with Leslie's point. Angelica asked, with the importance of family and community support, how should we go about addressing this with the COVID visitor restrictions within the hospital setting? In some ways, there's a public health safety issue here, but here's a family and community support issue here. How do we navigate that? Mike and Leslie, any wisdom there?
It's a huge challenge. I think we've all struggled, you know, mightily with this, and I don't want to say that this is just a unique problem for Indigenous people. I know that you know, we all care about our families, and it's really frustrating when you've got a loved one in the hospital and you can't visit them. But you know, specifically with a lot of our protocols, especially around end of life and you know, in times of critical illness, there are things that we just need to do, and the pandemic has really interrupted how we care for our loved ones. So I mean, I'd encourage those who we've had to go through this process with our clinic. You know, a lot of our elders haven't been able to actually be at the clinic in person seeing people because of their own health and wanting to protect their safety. And that's made it really difficult. So we've tried to where we can, you know, move things virtually. So virtual elder visits, it hasn't always been a smooth process. I'll be honest there, but that's worked in a lot of circumstances to try and, you know, as much as we can. There's a lot of things that especially with ceremony, that don't translate well into a virtual setting, but it's you know, it's something that you can try. And the other thing is just being creative. You know, we had a family at our clinic who really needed support. And there was a young father who had a cardiac arrest, you know, witnessed by seven of the children, you know, and his partner ended up doing CPR, saving his life really before EMS arrived. Really traumatic experience for the whole family, and we wanted to honor them in a way that you know, fit their cultural background and their need to process that experience. And we found a way to do that outside. You know, our elder was able to lead a ceremony outside. We were distanced, we had masks on, but we were outside where that risk was much lower for any sort of COVID transmission. And it was still small. There were only about maybe 12 of us all together, but we were able to do that in a local park, and that was a way that we could honor that family and that father's illness. in a way that that was safe. So sometimes we have to come up with these creative solutions, and that all comes down to discussing it with your patient, with your family, with the elder. Sometimes you have to ask some questions about, well, what's integral to this particular ceremony, or what's integral to this particular tradition. Are there ways that we can make that work within these parameters? And you can actually get some really beautiful outcomes in that struggle and in that challenge too.
Well, thank you, Mike. I see David is back, which is great. I hope. Oh no, David, are you frozen again? Oh no, there. Okay, I see a lovely smile. Maybe before I hand to David, Leslie, do you have any other comments on that? Because I'm going to ask David to make comments on the previous cases, and then he'll take us to home plates with his last piece of the presentation. Leslie?
Thank you so much. The one thing I'll mention is our Indigenous patient care clinicians. So these are Indigenous nurses who work in our hospitals at VCH and LGH and one that ropes. They have been an incredible addition to our team. They've only just joined in the last 3 months, but they can bridge that ceremony at the bedside. We do have iPads and other technology to help link family members to their loved one, and it has been effective, and it has filled the gap for now. But yeah, nothing beats having your family with you, and we totally acknowledge that, and we do our best to troubleshoot and make things happen, but it's really difficult. Oh, and David did this 2 thumbs up. He's back on.
I could be gone in any moment, and I apologize
Go for it.
for internet connection, but I'll try sharing my screen just to try and bring us home if we can. So I think we've talked a little bit about Kilala Lelum, and I just wanted to mention there is a lot of deconstruction and reconstruction and rethinking how we provide care. And this is just sort of a graphic of how some of the players at Kilala Lelum and the difference in values and mandate and missions that are nuanced from how we usually practice care, and how this more complicated circle started off with the patient medical home model and evolved from there. Mike, do you want to just comment as we can just drive through?
Yeah, really briefly. So Luma is now in its 5th year of operations. We've basically, we're located, for those who know Vancouver, at the corner of Nanaimo and Grandview. We wanted to be located outside of the downtown east side, where a lot of Indigenous organizations and social services are located, and basically to provide a place where we'd focus on safety as kind of the cultural safety as the central tenet to our model. So we have a team-based model of care. We focus on these eight strategies. So culture and all that we do, authentic engagement. So trying to bring down those power dynamics and reach people on a personal level. Looking at upstream solutions, so focusing on young generations and trying to interrupt that cycle of trauma. Opening doors of opportunity, so we partner with a lot of other social organizations within the Luma umbrella of social services, but trying to connect people with supports that they need for their social determinants of health as well. So housing, jobs, and other social services. We have a robust sort of e-health backbone. So we have good data working with our partners in the Aboriginal, First Nations and Aboriginal primary care network. Our physicians are all faculty members at UBC. So we also try to strive for excellence in Western medicine within our sort of 2-eyed seeing model. Culture as a focus of treatment, and then a sense of permanency. So really trying to attract staff that want to be here long-term so that we keep those permanent health relationships. And just so you know what that model looks like in terms of team members, we have elders and traditional healers, helpers who work with the elders. We have family physicians, specialist physicians, so 2 pediatricians, a midwife, partnering team of midwives, I should say, NPs, nurses, registered nurses, social workers, counselors, and now a dietitian, and soon to have a physiotherapist as well. Yeah, and I just, again, this is, I'm sure, common to what you guys do over at KL as well, David, but we're really trying to move beyond that solely sort of biophysical approach, and also embrace mental and emotional and spiritual aspects of health, and really focusing on that relationship. So we spend a lot of time on our first visits. We call them welcome visits, rather than the meet and greet or intake visits. Really embodying this concept that the relationship is the intervention. We spend a lot of time in that first visit just establishing safe space, trying to listen, trying to hold back on that feeling of wanting to interject. I think we like to do that as physicians sometimes. Recognizing that our patients are storytellers. They're experts in their own health and their own identity, and sometimes just stepping back and listening, you'll hear what you need to hear within that. Yeah, I'll leave it there.
We couldn't take the slide down just because it kind of brings it home. So this is from the Truth and Reconciliation Commission. We call upon those who can effect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration, I might say partnership, with Aboriginal healers and elders where requested by Aboriginal patients. This is a beautiful diagram, which we're not going to talk about at all, but it's worth looking at in the In Plain Sight report. We did the questions just to bring it back to our initial goals of understanding the historic and ongoing determinants of health. I think to bring this back, to think about those distal, intermediate, and proximal determinants, that sacred tree diagram, I think is very useful, kind of just, again, as a paradigm when you're meeting someone to see beyond the surface of their story, to know that there's a greater story, and know that their systemic racism has been at play in this person's health, and our job is to really try to counter that. And again, supporting someone's, and it's true of all people, of all whatever culture, that if you have a strong positive sense of who you are as a person, you're going to make better health decisions. And so just supporting that. The challenges are the lack of resources, the reality that trust needs to be re-earned, the power dynamic differentials, the historic and the ongoing traumas. But again, I think the approaches have been spelled out for us. Cultural humility as practice, cultural safety as a goal, practicing anti-racism. Basically, do your job and do it really well, particularly for Indigenous people. That relational approach, be innovative, bring new resources, deconstruct, reconstruct, or just really improve, but don't do the same. I think that is the bottom line. And that there's a place for us to partner together with Indigenous medicine providers. And that can really capitalize on that identity as a determinant of health. And I think hopefully we talked enough about how to do this in a way that makes us a good ally. So I will bring it to a close and say thank you. Haichko Siam, which in the Halkom Lelum language is an honoring thank you. So really appreciate everyone's time and this opportunity to share with you. Thank you, Mike, for doing this talk with me as well.
Thank you, David.
On behalf of Great. On behalf of everyone, I want to thank Mike and David. We have 15 seconds. I'm going to ask both of you one question. Many people are wondering whether you might be able to share your slides with them. Is that possible?
There's a lot of pictures. As soon as we figure out how to email them or send them up, we can do that. Yeah.
And it's all recorded too, so that's another way.
Exactly. So we will, for everyone, thank you very much for being here. There's a link on the chat. If you can click and do a survey, let us know your feedback. We want to continue to improve on these rounds. And we will also send you the link of the recording of today. With that, it's at 1:30. Thank you very much, everyone. Have a wonderful afternoon. And again, thank you so much.